Good morning, everyone. I am Dr. Satyabrata and today I am going to discuss on recent advances in rheumatoid arthritis. I will focus on the introduction, pathophysiology, clinical features, lab findings, complications, quality of life, recent advances in management, clinical trials, and next I will summarize. So, rheumatoid arthritis is a chronic autoimmune inflammatory disorder of unknown etiology that occurs in approximately 1% of the population, that is given by Albani and Carson in 1997. It is common autoimmune disease associated with progressive disability, systemic complications, early death, and socioeconomic costs. It is more prevalent in women than men and develops in the fourth and fifth decades of life, and symptoms are pain, stiffness, and swelling of the joints, resulting in impaired physical function, and often accompanied by constitutional symptoms such as fever and malaise. That was given by Gracie et al. 1998, and synovial inflammation can occur. So, this is the pathophysiology showing the epigenetic involvement and susceptibility genes and the other factors like smoking, etc., gut microbiota, these are involved in case of rheumatoid arthritis. And this is a complex mechanism of involvement of B cell, T cell, and plasma cell, etc., in rheumatoid arthritis. And these are some single nucleotide polymorphisms happens in case of linked to rheumatoid arthritis, like F3, PTPN22, HLA-DR B1. These are some examples of genes involved with rheumatoid arthritis. And these are some mediators like TNF alpha, interleukin 1 alpha, interleukin 6, 7, interleukins, other type interleukins involved in rheumatoid arthritis. So, coming to clinical features, the patient will complain of joint pain, swelling, fever, fatigue, morning stiffness, and deformity, etc. And if you do lab investigation, then you can do CRP, C-reactive protein, that is C-reactive protein, ESR, erythrocyte sedimentation rate, anti-CCP antibody is most specific for rheumatoid arthritis, anti-MCV antibody most sensitive, and MRI can show the synovitis, joint effusion, bone marrow edema, and in case of in ultrasound that can show synovitis and erosion. So this is the new classification criteria for rheumatoid arthritis, like symptoms, joint involvements. The score will be given, and according to this chart, we can find out the score for rheumatoid arthritis and grade the rheumatoid arthritis. This is the scoring system, another STAI scoring system can be used in case of rheumatoid arthritis. These are some approved immune targeted therapies in rheumatoid arthritis like adalimumab, that is TNF alpha inhibitors, like adalimumab, sotolizumab pegal, etanercept, golimumab, infliximab, and interleukin 6 inhibitors like tocilizumab, interleukin 1 inhibitor, anakinra, CD20 monoclonal antibody like rituximab, and CD and co-stimulant blocker like abatacept, etc. can be used. And this is the mechanism of rheumatoid arthritis affecting the bone and involving the TNF alpha and other mediators schematic rheumatoid arthritis disease burden, articular disease, joint inflammation, cartilage degradation, bone erosion, loss of joint function, and psychosocial aspect like impaired quality of life, fatigue, depression can occur, cognitive dysfunction, and comorbidity like cardiovascular disease, osteoporosis, lung disease, infection, malignancy. This can occur. Coming to management, non-pharmacological management is physiotherapy, occupational therapy, hand exercise programs, podiatry, psychological interventions, diet and complementary therapies, surgery, pharmacological therapy like NSAIDs, CDMARS, disease-modifying anti-rheumatoid drugs, steroids, biologicals, biosimilars, and new therapies in research like gene therapy, nanotherapy, stem cell therapy, etc. So, in case of these are some example of DMARDs, disease modifying anti-rheumatic drugs like methotrexate, inhibits it is the antifolate, leflunomide, it is the pyrimidine synthase inhibitor, hydroxychloroquine, anti-malarial drug can be used. Anti-malarial, that is hydroxychloroquine, can be used in rheumatoid arthritis. Minocycline, that is 5-lipoxygenase inhibitor, tetracycline antibiotic, and sulfasalazine, salicylate, and azathioprine, that is purine synthase inhibitor, cyclosporine, calcineurin inhibitor, cyclophosphamide, alkylating agent, biologicals like adalimumab, TNF-alpha antagonist like golimumab, infliximab, sartolizumab, and CD20 like rituximab, IL-1 antagonist like anakinra can be used in rheumatoid arthritis. And this is the tight control of rheumatoid arthritis TICORA treatment protocol. Sulfasalazine 500 mg daily, increasing every week to target dose of 40 mg per kg per day or maximum tolerated dose. Sulfasalazine methotrexate, sulfasalazine 40 mg per kg per day, methotrexate 7.5 mg per kg, 5 mg per week. Folic acid 5 mg per week, hydroxychloroquine 200-400 mg per day, less than 6.5 mg per kg per day. Triple therapy with monthly increments of methotrexate dose by 2.5 mg per week, maximum 25 mg per week. Triple therapy with weekly 500 mg increments or sulfasalazine dose, maximum 5 gram per day in divided doses if tolerated. Addition of prednisolone in enteric coated tablets 7.5 mg daily. Change triple therapy to cyclosporine, methotrexate, folic acid if previous step not control the rheumatoid arthritis. And at last change to alternative DMAT, leflunomide, sodium orothiamate. And available DMATs are auranofin, azathioprine, cyclosporine A, sulfasalazine, methotrexate, etc. And current biosimilar are on market and pending approval in United States like CTP13 infliximab, that is approved in United States 2016, and Trial Planetra and Planetra extension, and GP 2013 rituximab reference product approval, current US clinical trial. These are some clinical trial current biosimilars on market. Coming to the summary of filgotinib selective JAK1 inhibitor trials. Darwin 1 trial, Darwin 2 trial. These are some trials undergoing for filgotinib used in rheumatoid arthritis. Summary of recent de-escalation trials, the Prisma, NEJM, and Preserve, etc. These are lots of trials given here, and this is original article published in JAMA. That is effect of filgotinib versus placebo on clinical response in patients with moderate to severe rheumatoid arthritis refractory to disease-modifying anti-rheumatic drug therapy. The Finch 2 randomized clinical trial. These are the backgrounds, methods, and interventions, results. Conclusion: significantly greater proportion of clinical response by filgotinib. This is another article, treatment efficacy and methotrexate related toxicity in patients with rheumatoid arthritis receives methotrexate in combination with adalimumab. The background is written, method, result, and in conclusion, in patients with rheumatoid arthritis initiating adalimumab plus methotrexate combination, treatment efficacy was achieved and increased throughout both trials while rates of methotrexate related adverse events remain steady. Coming to summary, the recent developments in the management strategies for rheumatoid arthritis have made significant contribution to reducing the disease progression and improving outcomes of patients. Identifying the candidates early in window of opportunity and aggressive target oriented approach can prove to be a boon to the patient in long run, and the addition of biologic agents to armamentarium of available disease modifying agents early in course of disease can result in satisfying functional recovery and even remission in patients of rheumatoid arthritis. And with judicious use of medication and careful monitoring, quality of life of the patients with rheumatoid arthritis can be surely improved. So rheumatoid arthritis management is very complex, and the patients quality of life can be improved with this use of these drugs according to the guideline. These are some references. You can go through these references and learn more and more for your future. Thank you very much. Jai Jagannath. Please like and subscribe my channel, and thank you again.